There's some pretty interesting health reform that's happening in Alberta right now, and today we're going to talk about that. Krystle Wittevrongel has written an interesting paper along with Peter St. Onge. It's called Entrepreneurship and Universality, the Way Forward for Healthcare in Alberta. And so she's written this for the Montreal Economic Institute, where she's an associate researcher. So Krystle, thanks for your time today.
Thank you so much for chatting with me today.
Well, thanks for coming. And I want to start off with something pretty interesting that you talk about in your report right at the top, because I think it's important for people to think about. You talk about the numbers in Alberta and a little bit of the history. Basically, the government has thrown a whole bunch of money at the system over the years. We're spending a ton of money in Alberta on healthcare, but yet we're not getting the results. Our waiting lists have also increased. Could you tell us a little bit about that?
Absolutely. So in Alberta, we've had some of the highest per capita health spending in the country, but we also see some of the longest wait times, like what you had just mentioned. And so between 1993 and 2019, we more than doubled our healthcare spending in the province. But in that same time period, wait times for medically necessary surgeries increased by 167%. So we didn't get the accompanying decreases in wait times that one might expect with such heavy increases in funding. And we look at wait times a lot of the time because they're valuable metrics, as they can be a useful indicator of performance management and quality in universal healthcare systems like ours. Mm-hmm. For example, when we compare with Quebec, so we spend 10.4%, so just over 10% more per capita. And we actually wait almost 67% longer to see a specialist after being referred to one. Once we actually see that specialist to receive treatment, we're waiting almost 76% longer. And this is all with paying 10.4% more. So it's pretty astronomical, I would say. And we can even look at it strictly with numbers rather than percents of health funding. Mm-hmm. For surgeries with established benchmarks like hip or knee replacements, in May of this year, there were approximately 80,000 people on wait lists, and 50% of these are waiting longer than clinically recommended timelines. Mm. So we're not seeing the outcomes translated here.
And that's the thing that I think often gets lost in the numbers. The people that are the stories behind those figures, right? I mean, thousands of people waiting. The government's been throwing all kinds of money at the system to try and improve things. It hasn't worked out. And behind those figures are people that are waiting in pain, right? Mm-hmm. They're waiting a year for hip surgery or whatever the case is. They're struggling. It's impacting their livelihood, potentially their chances of work and earning income, et cetera. So it's I think very important that organizations like yours are studying this and putting out this information to talk about how we can improve, because it really is affecting people. And the thing I especially like about it is that you've demonstrated with your research very well that throwing a whole bunch of money at a problem doesn't mean that you're going to address it. Mm-hmm. And I think that's really important for people to think about as we look at Canada's healthcare system. There are many things that work right, but there's a lot of things that need a lot of improvement. For example, our waiting lists. And so this idea that we just need to go out and spend a whole bunch more money, I think is misguided. I want to now shift a bit to what your paper is really about, and that is looking at Alberta and what's happening there. They've got an Alberta surgical initiative moving forward, and they've kind of copied something that happened in Saskatchewan a few years back, and you talk about that in your report. Could you give us a short briefing on what Saskatchewan did and what's happening in Alberta?
Sure. So back in December of 2019, the Alberta government announced this Alberta Surgical Initiative, which they positioned was going to provide up to 80,000 more publicly funded surgeries over the next 4 years, mainly to tackle these wait lists, but also to ensure people are receiving care within the clinically recommended timelines. So this was pre-COVID. We've seen a little bit of a delay with how this is actually going to roll out, so keeping that in mind, of course. But as you mentioned, the Alberta Surgical Initiative is based on the Saskatchewan Surgical Initiative. And so this was a 2010 initiative that looked at Saskatchewan's wait times and promised that by 2014, so again in a 4-year period, that no patient would wait more than 3 months for surgery. Mm-hmm. So what Saskatchewan did is they changed how waitlists were managed by prioritizing patients differently, but also using private for-profit clinics to deliver covered publicly. And then by 2016, they saw wait times for elective surgery among the shortest in Canada. So we've got the private provision of publicly paid surgeries, and that translated in some measure, along with some other things, into shorter wait times for Saskatchewan. And so Alberta is based on that, and we are aiming to improve and standardize the entire surgical system, but also looking to utilize some of these non-hospital surgical facilities for elective surgeries like hip and knee replacements.
So really, you've got the government contracting with a private company saying to them, okay, you guys go out and provide these extra surgeries that we need for patients, basically free of charge to the patient. I mean, they pay for it through their taxes and that, but if you need a hip operation, the public system's capacity is only so much and it's backed up, well, then they might say to that patient, well, okay, well, you're going to go to this private clinic. Don't worry, you don't have to pay for it. They're going to do it. They have to meet the same standards as the public system. You can't just have anyone doing hip surgery, right? You've got to be qualified and it's got to be a clean facility, et cetera. So from a patient perspective, it's really, they don't really notice much of a difference, do they? They're still getting their hip surgery. It doesn't cost them anything directly.
No, and the patient really shouldn't even know that it's a privately provided service, because again, it would be publicly paid. Yeah. And these non-hospital surgical facilities, such as the ones that will be contracted with for the Alberta Surgical Initiative, have been used for years and years. Like, this isn't a new thing in Alberta. It's just kind of amping it up a little bit more to look at our waitlist problem. That is the newer focus, it seems.
Yeah. And that's a good point, because we actually spoke with a patient from Alberta, Danny Hozak, and people can see his video on Facebook and our YouTube page, where we talked to him. He had a problem with his eye, and I think it occurred on Christmas Day or Christmas Eve. It was right in what you would think would be the worst possible timing, but he ended up getting help very, very quickly. They fixed him up, and it was, I think, a sort of almost like a partnership between the government and a private company, and together they provided him the services that he needed, and he was very pleased with how that worked out. Now, some critics obviously are, they like to fearmonger whenever there's changes in healthcare. They don't like the monopoly challenged, and they're referring to this as Americanization. But when I think about it, it just seems kind of similar to like when you go and visit your family doctor. Your family doctor is basically running a private business, but they get their revenue from the government every time a patient walks in the door and they help them. They get fee or money on a fee for service basis. So it's kind of similar, isn't it? Like, if you're the patient, you're not getting a bill from this. It's just a private company is going to be helping you out with your healthcare problem.
Exactly. And so again, the Alberta Surgical Initiative is expanding contracts with these facilities that are publicly funded. So there's no bills to patients. This isn't a bit like, you won't even know the cost of what something like this costs. And generally speaking, Canada has a mixed public-private system currently. As you mentioned, visiting your family doctor is a privately delivered, publicly paid service, like what some of these surgeries are positioned to be. And so we can see that it's perfectly possible to have a quality mixed public-private system while maintaining universal coverage. It doesn't mean one or the other. This is actually the case for virtually all of the economically developed countries in the world, including some whose public coverage is actually more comprehensive and generous than that in Canada. Like, for example, if we look at Europe, countries like France, Germany, Sweden, all of these countries rely on entrepreneurs to various extents to deliver their healthcare within a universal system. And the MEI had actually commissioned a poll back in December of 2019, and 63% of Albertans polled were open to care provided by entrepreneurs at that time, provided it was publicly paid. So there is an appetite for this here in Alberta, and it is so important for it to continually be emphasized. This is a public paid service. It's not private healthcare or American healthcare. Looking at some of these European models provides us other ways of doing things or other ways of looking at things.
And I think that's certainly going to be the government's challenge, is to cut through the noise, those that are trying to suggest that this is the, the Americanization of the system. And in fact, as you pointed out, it's just really using some of the strategies that have been placed for a long, long time, including in Alberta under the previous governments, and just sort of broadening those with the ultimate goal, getting procedures done faster for patients while maintaining that quality and the fact that people aren't going to have to pay for it. I want to just ask about this. You mentioned that there was a legislative change that would be happening to support this. Under that legislation, does it mean that if I, for example, as a patient, do not want to, let's say that even with this new Alberta surgical initiative, my wait time is still, let's say it's 6 months or a year still for a particular procedure, and I decide I don't want to wait that long. I want to get my hip done sooner. Can I go to one of those clinics and say, okay, I just want to pay and get it done? Is that something that would be allowed?
So just going back again with the Alberta Surgical Initiative, this is all publicly paid. I just want to put that out there again.
Yeah.
But in Alberta, so all medically necessary surgeries are covered and fully paid for under our public healthcare system.
Yeah.
But there is legislation, and it's been in place for years. This isn't a new legislation, that the way that it's structured is that if a provider opts out of the public insurance plan, they can charge patients privately for services. So yes, patients can pay out of pocket if they want to and are able to, but this needs to be done with a provider or a physician who is entirely working outside of the public system, so they cannot be billing publicly and privately at the same time. And the patient cannot claim reimbursement for this service. So they would be entirely out of pocket at that point. We do know that surgeries are typically prohibitively expensive for people. So there's been little room historically for a market to develop for such payment in the absence of like a private parallel insurance option or allowing physicians to operate in both the public and the private sector.
Okay, so they have to pick a lane basically. Either you're operating within the public system or you're operating outside of it, but you can't do both.
Exactly. And then you are only able to be targeting patients who can pay entirely out of pocket, that cannot rely on any sort of insurance, whether it's public healthcare insurance, like Alberta Healthcare Insurance Plan. And then there's no such thing as a private parallel insurance for these medically necessary surgeries.
There's an interesting story that's kind of related to what we're talking about. It's on the Calgary Herald, where there was a surgeon in, I believe it was in Calgary, and what he would do is because of that rule that you mentioned, he couldn't operate in his spare time outside of the public system. It wasn't allowed. So what he would do is he would fly down to the Caribbean somewhere. His patient would go down there too. So you'd have two people from Alberta flying down into the Caribbean, and they'd do the procedure down there. So he'd get compensated for it. And then maybe some other patients would fly down at the same time, and he'd do a bunch at once and then fly back to Canada.
Wow. So there's our system losing money.
Yeah. That's something we've been doing a lot of research on, is looking at the economic side of this to say, well, how much money is leaving the country when all these people are just going abroad and paying for procedures? Whether it's with a Canadian physician in another country, or if it's, paying an American clinic or one in China or Thailand. We've been talking to people who've been going all over the world. So there's a huge economic opportunity that we've missed. But you talk about something really interesting in the report, which I think is interesting for Canadians to think about, and that is this notion of activity-based funding. Could you give us a little bit of a briefing on that, like sort of the 60-second briefing on how does that work? How does it differ from Canada's healthcare system? Because I think it's interesting, and it'll get people to sort of think about the system differently and how we can change the incentive model to increase productivity and get to ultimately deliver better services for patients.
Totally. So currently, hospitals in Canada are largely funded with global budgets, which means that they are provided a fixed amount of funding for a fixed period of time, which is normally a year. They are not funded for individual services or cases. This sort of funding focuses on budgetary control rather than on the value of the care provided or on the patient outcomes. And it also actually sees patients as a cost, which can be problematic. And so to stay within available budgets, the system must delay or restrict the delivery of services to patients through rationing. So that's our current hospital-based funding model.
So it's,
And
to interrupt you for a second, it's sort of like the government says to hospitals, say, here's $100 million. Good luck. We hope you do a lot of procedures and help a lot of people. Is it kind of similar to that?
yeah,
Yeah.
and it's, as far as I understand, and I could be wrong on this, but historically it has been on previous years.
Yeah.
And so it's kind of moving forward with what has historically been the case rather than looking forward and saying, hey, this is what we're facing.
Mm-hmm.
It's kind of, oh, what have we historically faced?
Okay.
Yeah.
And sorry, with activity-based funding, how does that one work?
And so that is a method of funding where providers are allocated funds based on the type and volume of services they're actually providing.
Mm-hmm.
So a hospital's revenue is linked to its activity. And in this sort of funding, patients are seen as a source of potential income or revenue rather than seen as a cost. And so hospitals that can increase their volume of services, they can benefit from increased revenue, but they're only able to do this if there's unused capacity or if additional capacity is generated through increased productivity or efficiency. So there's an incentive there to make things more efficient, to be able to increase the volume of services. And so activity-based funding has become the international norm. And most high-performing universal systems utilize some sort of this for their hospital-based care. And these countries also tend to see increased number of services, reduced wait times, and increased efficiency. For example, like France, the Netherlands, Sweden, and Switzerland, they all employ some sort of activity-based funding for hospitals, and they all have shorter average lengths of stay in hospital than we do here in Canada.
So it's, instead of just, to go back to this example we talked about where, you cut a check for $100 million to a hospital and you tell them, good luck, we hope you do a lot of services. You're saying to the hospital, we're going to pay you, say, X amount per procedure. So then the hospital has the incentive to do a lot of those procedures rather than just, carrying on the way that they always have. I think about, we often hear about the bureaucracy in healthcare and how it can eat up costs. But if you change this incentive model to the one that you're talking about, then the hospital has the incentive not to pay a lot of people to do administrative work that may not be that valuable, but to instead focus on, let's get a lot of hip procedures done, let's get a lot of knee procedures done, et cetera, because we get paid every time we do one, right?
Mm-hmm. It definitely shifts the incentive to more productivity or efficiency rather than global budgets incentivized.
Well, that's interesting that so many other countries do that, and it's something that Canada could change pretty easily, I would think. And I've heard this concept come up many times over the years, and it doesn't seem like anyone in Canada has really made that shift too much, have they? Except for, I guess, kind of what you're talking about with Alberta, where these private companies are going to get paid based on how many, say, hip procedures they do for the system or knee procedures, et cetera, right?
I'm not entirely sure how activity-based funding fits in with the Alberta Surgical Initiative or with how they are going to be moving forward. So yeah, I'm not sure exactly how that plays in there.
Okay. Now I want to end off on a fun question here, and that is that if you're the Minister of Health, whether it's in Alberta or nationwide or at the federal level or some other province, and you have all the power necessary in this magical scenario that I'm creating.
Oh wow!
What changes do you think needs to happen to really improve the system for patients? I mean, your paper obviously talks about activity-based funding. Are there other changes that you think could be tweaked or implemented so that we see some really positive improvements for patients?
Oh, definitely. This is a great question, actually. So I think that you kind of opened the discussion with this and how dumping money into our system isn't translating to better outcomes. So we need to look at the structure of the healthcare system and how do we support that structure to be able to effectively manage increasing demand, because demand's increasing, funding increases aren't going to do much for us.
Mhm.
And so evidence out of Europe, as we discussed in the MEI paper, shows us that it's possible for the private sector to operate in a parallel system, whether it's delivering medically necessary hospital services or financing and delivering healthcare services. We can maintain universal access and get better outcomes. So we need to introduce some changes that utilize some of the basic economic principles like enhancing competition, like you mentioned, through activity-based funding. Or another area that I think is really interesting and I've been looking into has been considering private parallel insurance. That can inject resources into the healthcare sector. It can increase patient choice in healthcare, as well as decrease the burden on the public insurance plan. So having a parallel private insurance to the public insurance plan. This is the case in Denmark, where pressure on the public sector is lower, access to care is better, and wait times are actually substantially shorter as well. And then looking at, we kind of talked a little bit about it with the opting in and opting out of physicians and what that looks like. So allowing a dual practice for physicians is another area that I would consider, which would make more efficient use of highly skilled medical resources. Like you mentioned, the limitations upon practice that are here within our universal system, or restricting the access of physicians to be able to operate more efficiently or provide more services. So putting those things together, I think, could be a really interesting way to support our publicly funded healthcare system and maintain access for everyone.
Well, that's interesting. And we actually came out with a report recently where we look at some of these alternative systems. It's on our website if people want to see it, where they can learn about, say, the Australian system or the Netherlands system and so forth. And I take it on your website, you would have some additional information about how those other models work as well, right?
Oh, absolutely. Through the Montreal Economic Institute website, there's been reports throughout the years, publications throughout the years, focused on various tenets of the economic principles that could be employed in small scale, but also in large scale, like in some of these European countries. So there's definitely evidence out there, and there's definitely reports to be read that are interesting and like yours on your website, provide a little bit more background to some of these issues.
Yeah, and I think that's important for people to start thinking about these other models, because so often our debate in Canada comes down to, do we keep our system or go to the American system? And it's, it's frustrating because there's so many countries on this planet. Many of them are doing better in terms of healthcare outcomes for patients, while keeping that universal aspect that I think Canadians love, the idea that, if you're low income and tragedy strikes, that you're not going to be faced with a massive bill if you have to go to the emergency room or whatever. But there's other models where they have that same approach as Canada, where people are going to be covered, and the lower income and middle class and so forth aren't going to be left behind. Finally, is there anything else that you'd like to add that we haven't touched upon?
No, I think you've kind of hit it all on the head there. I just want to always return it back to, it doesn't have to mean an Americanization of the healthcare system. There are these other models in Europe that are high performing, better outcomes, and that still maintain access and equity for patients. So it doesn't mean access versus private. They can all be combined into something that provides better outcomes for patients, like you had mentioned.
Well, that's a great point to end off on, because it's certainly true. And again, your paper is Entrepreneurship and Universality, the Way Forward for Healthcare in Alberta. And certainly, as we've talked about, there's lots of lessons for other parts of the country to consider from that paper. So thanks again for your time, Krystle, and the work that you're doing on healthcare reform.
Yes, thanks for having me. This has been great.
Sounds good. Take care.
All right, you too.